Hi, I'm Dr. Julia Overstreet. I've been in practice about 35 years, and one of the things I've learned is sometimes you need to find a common sense and traditional padding or something to relieve pressure, relieve the possibility of wounds or infections, and that's what we're going to talk about today. There are some wonderful pads on the market for different types of toe deformities, bunions, that sort of thing. So let's look at those. How do toes fit together? Well, you can see here, it's kind of a whimsical picture there on top. There's a lot of curves in toes. Now, sometimes the toes we see in clinic, they're swollen and you don't see this necessarily, but this is what it looks like under the swelling as you were. So that's what's happening. Sometimes the knuckles are in alignment with the kind of the groove in the toe next to it. So it can go into kind of a divot area. Other times the toes have moved a little bit or been injured, and now the knuckles are rubbing on each other. That's when we start to have problems with this. So see on this second toe here, it does fit kind of nicely in the groove of the third toe. And that's probably not going to cause any problems. But on this one, it's a different foot here. It's a little bit closer. So the joint on the second toe is really close to rubbing on the joint on the third toe. And with any kind of movement with this longer toe, and that's common when it's a longer toe, it tends to get contracted. Then you can guess that those two knuckles, those two joints are going to rub on each other and the skin caught in between. And when it does, it can be a sore like that. Now, if they're neuropathic, they don't feel it, but that's actually bad because they don't know to do anything about it. And then first thing they know, they have an infection from an open wound there. If they don't have neuropathy and they do feel it, they come in to see you because it hurts. And they need something done about it because it's affecting their daily activities and their quality of life. What can cause toe deformities? Here's a big list. We get asked this all the time. They want to know, what is it? And it can be any of these things. And by the way, the first one, motor neuropathy, is most commonly now found with diabetes. We know about sensory neuropathy, but motor neuropathy comes along with that. And the motor neuropathy, as the name implies, excuse me, affects the pulling on the muscles, and therefore the toes can get pulled into different positions. But all of these here, gait disturbance, plantar plate disturbance, that's the anatomy on the bottom of the forefoot. Now that can have injuries or other abnormalities that also can cause the toes to curve. Shoe fit issues. Obviously, if the shoe is too short, that's going to cause problem. If the shoe is too big, it's going to cause problem because the foot kind of has to hold on to so you don't fall over. Trauma and injury, genetics, neuromas, tumors, masses, it can be any of these. And that's what I know in your clinics you look at, is to kind of determine what the cause of this is and therefore what the treatments can be. So we're talking about interspace, or otherwise known as interdigital lesions. The fancy, or the not so fancy name for that is kissing corns. It's what we saw on the x-ray a minute ago, phalangeal prominences of two adjacent toes are rubbing. Okay, and here's a little more dramatic picture of it. Whether it hurts or not, this is pre-ulcerative. It can get infected really easily, and if they're not neuropathic, it hurts a lot. Here's another couple of x-rays. You can see right here, this little exostosis on this bone is because, I know it's not in this x-ray, but in real life, that toe curl, the fifth toe curls under the fourth toe a little bit more because of shoe wear, and that little exostosis rubs there. Kind of the same thing. This is a different x-ray, kind of the same thing. So, same thing there. That's really common. Come on. And that's the fifth toe. That's what it is. And if you were to put, I mean, I've done this many times, put a lead BB on that, or whatever marker, and when you're taking an x-ray, you would see that this coincides with this exostosis. Minor surgery can be a permanent correction for this. What they would do is just numb up the fifth toe, or whichever toe it is, where the anomaly is, make a little incision, and just take off that little spur. That's all there is to it. It's like a half-inch incision. You can do it in the office. I've done it lots of times. And it's safer to do that than to let the person walk around with this infection brewing all the time. So I know that sometimes there's resistance to doing this very minor procedure because the person's older, or the person's not they have diabetes, some other problems, but that's exactly when you need to do something like this. So there is a permanent correction for it, but it is surgical. There you go. That's where the incision would be. But let's move on to what we're going to do either before that happens or instead, if they truly aren't a surgical candidate, or it's just decided that that's not the way to go. Lots of different kinds of inner space protection. We have this gel material that goes in between, a foam, different densities of foam that can go in there. Here's lamb's wool. You just kind of move, I just kind of make it a U shape and put it, you have to put it between two inner spaces just to hold it in place. So that this doesn't imply that there's a sore in both of these inner spaces. The sore actually was on the medial side of this fourth toe, but you have to hold that on there somehow. So lamb's wool, you can get a pound of it for, you know, I don't know, it's $20 or something. That changes, of course, but these are little, I call them toe sleeves, and they have silicone pads on the inside. And when you put it on, it looks like that. So you would move this around to where that sore was on the pictures of the interdigital sores we saw before. This is a silicone toe sleeve, and it protects both the distal tip and the sides, because you can certainly have, and we'll look at some, you certainly have lesions in all different places on the toes. So different ways. Now, having said that, they have to be able to reach them, or a caregiver reach them. If it's a 90-something-year-old woman with severe arthritis, she can't reach down, and she doesn't have a caregiver, you'd have to work with whoever is taking care of her to work on this. So, so please do be aware of that. You have to be realistic about it. These are phenomenal pads, but they have to be something the patient can and will use. Here's another type. This is one of those toe socks that's kind of inside out. It has a bigger gel pad there than the one you saw in the previous one. This is a patient I actually just saw a couple of weeks ago. She has a lot of pain right here on the distal. It's an unusual place, granted. It's on the distal interphalangeal joint. You can see it here. That's an unusual place for it, but this toe pulls up. So this spot rubs on the hallux interphalangeal joint, and that's real painful for him. We've tried a number of different things, and this one is actually working. You can kind of see it in different places here, and it has a nice gap. It does, but these little wings on each side, there's wings on each side of this, hold it in place really well, because this one works well on the lesser toes, but because they don't get so much movement, but the great toe gets some movement. So I like this one that kind of sits there like a saddle and kind of stays where it is. Those are awesome. So hammer toes themselves, as we said, there are many reasons for it, but you must choose a device that works in each of the two situations. Hammer toes can be one of two general types, reducible or fixed. So reducible means that the toes can be straightened out, okay? Fixed means they're frozen like that. You can't straighten them out. So it makes a huge difference what type of pad you're gonna put on them. It also makes a difference, for instance, on this one, you can see where the tip of all of these toes, or at least those three, are getting just pounded with every step, and we're gonna look at that in a second. Also, when they're like that, the dorsal aspect, the raised aspect, is going to hit the shoe more, which of course can be painful and can create lesions at that point. But deciding on which pad or which device, can you reduce them, straighten them out, or are they frozen like that? Really important to know. So this one, for instance, and I'll show you the pad by itself in a minute, it's a nice cushiony pad that goes under the ball of the foot. It doesn't go all the way back. It's just under the ball of the foot. And it has elastic loops. And there are different versions of it with 1 loop, 2 loops, 3 loops, depending on the situation. On this one, I think I would use all 3. And if it's reducible, it will hold them down. And it really helps. It prevents the pressure from both areas. But if they're already frozen in that, you can see that type of pad wouldn't help. So that's what I'm talking about. This is a perfect pad when they can straighten their toes out. Here's that distal tip problem I was talking about, where they, in this case, this person only has the distal joints frozen, not the proximal joints. That's technically called a hammer toe, a mallet toe. And it's frozen like that. So we can't use anything in terms of padding to straighten that out. So it is just that distal interphalangeal joint that's frozen, but it's frozen. So we're going to have to do something to take this pressure off so it doesn't become this. Very, very common. So this is an age-old type of pad that now has a new look to it, new materials. It's called either a buttress pad or a crest pad, and its whole purpose in life is to relieve distal pressure on the tips of the toe. That's it. It doesn't do anything else. It doesn't stop on the top. It doesn't, nothing else. But it works incredibly well on this. I have used these versions of these for my whole career. And when people aren't neuropathic, they come in begging for them if they can't find any. This is a very successful pad. It comes in different versions. This is sort of a felt version. This is that silicone version, suede or felt, and it also comes in either 1 loop or 3 loops. The person has to be able to get this on. This isn't the easiest to get on. And they have to be able to take it off too, because it's not good for the skin health if they leave it on for a week at a time. So be sure to tell them that too. It kind of snuggles down here under, it's called the sulcus, and you know that. This is called the sulcus. And when you don't have contracted digits or hammer toes, you see on the bottom all the toe shafts. But when you have contracted digits, just like these pictures, you really don't see the shafts of the toe. So the sulcus is under there, even though in these pictures you don't see it so much. That one you see a little easier. So these things snuggle up in there. It doesn't hurt. There's plenty of room for it, although all of these things come in small, medium, and large. And there's one that is bilateral. Most of them come either right or left for the right or left foot. So I tell the patients the big part of it goes toward the big toe. So this one would only be for whichever foot this is. It wouldn't be the left foot. Sorry, the left foot? Anyway, you wouldn't put it on the other one. See the point? Because the bigger part of the sulcus is in that first inner space area. So that goes under there and just lifts it up enough that you're no longer hitting on the distal tip anymore. Not so much that it takes up room in the shoe. I've never seen any secondary lesions. I've never seen any shoe fit issues from this. It doesn't do that because there is a gap up there, the sulcus, where that can fit. Few little details on this one though, particularly on this. So this elastic band is movable. So you can see here is a little, it's fixed, glued on that side, and it's adjustable on that side. It's not glued. What people can do, unfortunately, is pull it too tight. So here's your tip of the day. If this is the kind that they're going to wear with the elastic band on it, have them bring it in, put it, excuse me, have them put it on. You get it the way you want it, where there's a little bit of space. It's not tight. It doesn't have to be tight. It's held under there because the toes are holding it under there. So leave a little bit of looseness in that, and then gently take it off their foot, turn it upside down, and super glue that second tab down, this one right here. Super glue that down. Now it can't pull in, it can't pull in and out, and they're not going to pull it too tight. Please do that, because I've seen some terrible things where they pull it too tight and cause some skin damage. I haven't seen anybody lose toes or anything, but it causes skin damage. So it's a really easy thing to do. Have some super glue, they appreciate it, and then it's elastic, it'll still go on and off just fine. So you fit it the way you want with a little extra looseness to it, and then you glue that edge down. I love that. Now that's not a problem with the silicone, with the Visco gel. So you can see that we've looked at those. See, this is the Visco gel form of the buttress pad. And don't do that, what they're doing in this picture, because it will snap. Okay, it's not like an elastic band. These that are actually elastic, you can do that too. Don't do that, it will snap. Eventually, it's a really good product. It's durable, don't get me wrong, but if you're sitting there doing like that, that's not gonna be good for the product. Here are those toe sleeves I talked about. This version has, it's closed at the end like a sock, and the entire inside is coated with that gel. It's not just one spot. Remember, we saw that when we were looking at an inner space lesion, and the silicone was just right there. But on this, it can help problems anywhere on the toe, including the distal tip, because the entire inside is lined with the gel, the Visco gel. So a new one to what we're talking about, and it's new to me, I've only been using it a short while, is called the toe crutch. And it's designed to, again, the toe has to be reducible. It has to be able to flatten out. But if it does, instead of that pad we saw on the first, where we had the loops that went over 3 of them and the pad that was underneath, you don't have to do that. Although that's fine. You can do this, where it's just a silicone gel device that goes over the toe, and it has this stabilizing part at the bottom, which means it's not going to roll or turn around, and it not only holds the toe down, but holds it stable, so it's not going to go, and you've seen them go under and over other toes and that sort of thing. So this toe crutch has been very successful. I've really liked using it. I've used it on a number of patients now. This is one of my patients. I've just recently used it on. And I wanted to show you this case because I had to adjust it with this, and that's just real life. It fits most people. It comes in small, medium, and large. It also has these little inserts. They're tiny. They're about ½ an inch long. I know it's hard to tell in this picture. Firmer and softer, and they're squishy. And what you do is you can put them into that base part if you need little more support under there. I've been using it with the softer or with the, because a lot of my patients that I've used it on so far are sweet little ladies. And so I think that's why my choice of that. And you just yourself, you see this little hole here, you kind of wiggle these pads. It comes with both in each pad. You kind of wiggle it into there. It's really easy once you realize what to do. I had a learning curve with that part, but you can use it without that as well, okay? Now, so this is the picture we saw, small, medium, and large. So this is a sweet, sweet gal, and you can see what the problem is. And that's before debridement and after. So she's had wounds there before, and I was nervous when I saw this, but I debrided it and it was fine underneath, in that it wasn't a wound. Here's a closer picture of, this is obviously not her foot, where you can see how it's kind of like a sled at the bottom that keeps it straight. So these are closer pictures and from the bottom. So that's like a platform. Now, having said that, for this sweet gal, I put it on her and what am I doing? Sorry, didn't mean to do that. And it didn't fit. Her toes, let's see what I did here, come on. Come on. Sorry, the pictures are out of order. Her toes, the way they were sitting, it was just, this base part was too long. It hit her here more than it was meant to do. Most of my patients, it's fine. It fits in perfectly. But on hers, she's a petite little thing, and you can kind of tell this is not her toe. But I don't have this angle. But like this picture, it's a really short proximal phalanx area. And so there just wasn't room for this because of this. Most of her toe was distal to the proximal interphalangeal joint. There just wasn't room. So most of my patients, it's fine. But I just wanted to fess up and tell you what I had to do, and I had to kind of whittle away on it. This ended up being the area where I cut it. So I cut a lot of that little sled or that little stabilizing piece off and adjusted it for her so that it would fit under there. Now this is her toe after debridement with this in there. Now it fits perfectly. You can see it bumps up there a little, but the way it's supposed to. And when it was out a little further, it got caught on the sock. So it was a little bit of a learning curve with her. And now it fits perfectly. She loves it, and she no longer has pain at all. She can take it on and off herself. She's very limber, and she's in her 90s, but she every day does that. And another little trick of the day, once you get it all set, even if you have it set without doing this many alterations to it, take a Sharpie and mark the direction. They get it home just like I would, and I go, I don't know which direction this goes. It's not really clear. Even before you take it off, before you do any adjustment to it, the way it comes out of the box, to me, it's a little hard. I have to look at the picture each time to make sure which direction it's supposed to go, although I don't think you would hurt anything either way. But do them a favor, and I do this with a lot of my pads. Mark the direction it goes. So, all right. Oh, that's just another picture of her. So see that there just wasn't room for it, but this works perfectly. So don't be afraid. This gel material is very adjustable. Just regular scissors. You don't need a grinder or anything, just scissors. And it worked great, and it's just as durable after that. Most of the time, I don't have to do that. All right. Pediplast has also been around for a long time. I've used it. It's Play-Doh, if you're old enough to know what Play-Doh was. It's great. It comes in a jar with an activator, and you take out the size of the amount, here you go, the amount you think you might need, like the size of a tablespoon or something, and it shows you how much of the catalyst to use in there, and then you squeeze the two together and you kind of mold it and get it all mixed up so that the activator starts the hardening process. And then you can make anything you want out of it. So it's Arts and Crafts Day. This obviously is just like those crest pads, buttress pads that we just looked at. But this is going to be more personalized, and it's going to look something like this on the top. That's going to be the bottom of it. Let's see, do I have that picture? Yeah. It's going to fit up between the toes there. So it doesn't have a loop around the top, because having that all the way through the inner spaces is going to hold it in place for all three of those. So you have to work with it. And because you have about, I better not say, I'm going to say a minute, 2 minutes. I better not say, because usually it doesn't take that long. You can make just an inner space pad, like we had some of those with the kissing corns earlier. These, I imagine, are for specific sores or corns on the tops of toes or different areas. So you can do whatever you want with this, and it lasts forever. And because this doesn't have any straps or loops over the top, it also doesn't break. It literally lasts forever. So something like this is another option. And what we do a lot with this is for people who have trouble taking things in and out, or for unusual types of pathologies where they don't make an over-the-counter type of product. This, or several different pathologies together. They have kissing horns and bunions, or they, you see that all the time. So this is fun to work with, and it works really well. It's very professional, and it lasts forever. So the Pediplast is really something to consider. Oops, here's another one. So that would be keeping the some kind of inner space lesion from between the hallux and the second toe. So very versatile. All right, let's move on. Overlapping toes. We see those all day, don't we? What are we going to do with that? Oftentimes it's that remember we talked about plantar plate disturbances. The plantar plate is down here. if something damages it and it lets go, this whole proximal phalanx can move up and out of where it should be. It should be down here, shouldn't it? This part should be down here. But once that plantar plate or the flexor tendon lets go, the whole toe can move up. And when that happens, they usually all do. So sometimes just one, like you're seeing here, sometimes multiple. Okay. So we looked at this one already. And again, what? It has to be reducible for this one to work, but it works great. It's called a Boudin splint, 2 and 1. So I guess with this one, they probably could have done it with 1, but there's different reasons. It's more stable. It doesn't turn, easier not to get on. There's lots of reasons. If it's reducible, this is a great pad. It also lasts forever. These loops are also adjustable. So I would see, you can see the pull tab right there. I would also do the same thing, get it adjusted and then super glue this tab underneath so it doesn't pull in some odd way. These are neat things. Most of the people I have wearing this are men. I'm not sure why or if that's just my practice, but for these wraps, I don't know why. So you can kind of see there's different versions of it. It's hard to describe, so you'll just have to see. But they do the same thing. They're going to overlap, they're going to overlap the toes and kind of buddy splint them together. So whichever model or version you have, people tend to like one or the other. And and they come 6 to a package. So they last a long time, but you know the way Velcro is. Well, it's not Velcro, but it's hook and loop and very fine mesh, by the way. So it's not at all something that rubs. Back to that Boudin splint. This is another kind of silicone like these are that you can see would go between two toes, or they can take that overlapping toe with just the one that we looked at a minute ago. So lots of options for that all work. Why do some people like one versus another? It's just personal preference. Maybe it's easier to get on for them. Maybe it doesn't take up room in their shoe. Maybe, I don't know. But that's why you need to know different options for them, because overlapping toes can certainly be painful and can create enough rubbing that it can cause wounds as well. So lots of options to get those overlapping toes down. All right, bunions and arthritis. So not everything that's in the first metatarsal phalangeal joint, not everything that's there is a bunion. You know that, but your patients don't. Sometimes it's just arthritis. And of course, bunions have a continuum from when they first start to form to when they're quite severe. So in this case, for instance, the bunion appears to be only on the left. Now, we'd have to do an x-ray to validate that. But just the way it looks, we have this hallux valgus. The great toe is moving laterally. So that's classic for a bunion because the metatarsals go in that direction, which leaves no option but that the hallux goes stays where it was actually. And that's a whole different class. We won't go over that now, and you probably already understand that. This one doesn't look, this toe is straight. It's not in valgus at all. All of these toes have nice spaces between them. So why would they have just bunions on one foot? Now, I know that a lot of people say shoes cause bunions. They don't. Bunions, like so many other things in the feet, it can be inherited. Usually it seems on the mother's side. My grandmother had bunions, and it can be inherited. It can be a result of an injury, or it can be the fact that one leg is longer than another. We all have one hand larger, one foot larger, which by the way makes shoe fitting difficult sometimes, but we all have one leg that's a little bit longer. And it's different degrees. It may be that it's long enough, it's not long enough to cause you gait problems or hip problems, but it's long enough that every single step, the longer leg hits harder. And it pushes you off a little more, it's a little more stressful to the joints to push off for the next step. That's the foot that's going to get the bunion, is on the longer leg. It just throughout their life, there's more pressure on it. So I think that's interesting. And here, bunion on the right only. Now that could be arthritis. I don't, because again, that toe is straight as opposed to this toe is in valgus. So is that just a little bit of arthritis? Is that a normal joint for this person? You'd have to, of course, do an x-ray or a scan to find that out. And bilateral bunions, findings, hallux valgus, yeah. Overriding toes 2 and 3, probable bursa right there. That's an odd round thing. I think if that were a bony prominence, it would be more irregular. And that's pretty round, like a big old bursa. And a bursa, of course, is an internal blister in effect. It's the body's way of providing padding to a bony prominence that's getting rubbed on. So you could, your doctor could take the fluid out of that, and it's kind of a jelly material. And sometimes they come and go, the bursas just naturally. So different degrees of problem. Topical anatomy. So when we saw that the hallux in valgus going off laterally, now this one's not too bad, but it's this toe's starting to come over there a little bit. So this is starting to go over. What's that bump? Hard to tell. Is that the beginnings of a bunion or is that arthritis? So here we go. Normally that toe would kind of be coming straight off of there, kind of more like this is normal alignment, where the joint is covering the whole thing. And here, this whole area doesn't have any toe over it anymore because the toe kind of fell off over there. So this is normal alignment where it's straight. This toe no longer goes that way because the hallux the metatarsal is moving medially. That's what a bunion is. It's the metatarsal moving because of forces that we'll go into another time. That leaves no choice, but the hallux stays where it was, which makes it look like it has lateral deviation. This is why the x-ray is good. Now, is this arthritis? That joint is beautiful. It looks clean. So, and there's no bony abnormality at all. It's just there's a wider space between the first and second metatarsals, and the hallux has deviated laterally. So that's your topical anatomy. You don't really know till you see the scan or the x-ray. So probably, like we talked about, that's lateral deviation, and that's not. That's probably a bunion. That's probably arthritis. Lateral deviation, okay. So regardless of whether the bump there is a bunion or degenerative changes, arthritis, there are some wonderful pads to keep it from rubbing because it gets painful. It can be painful just from the motion, and these will help a little bit with that too. But the thing you have to be careful of when you're getting devices like this is that the device itself is a high quality like these are, where it doesn't take up extra room in the shoe, because you can actually increase the pressure on that bony prominence if the device itself is thick. So stay with quality products. You can see this is thin, but it's certainly thick enough to prevent rubbing and chafing and bumping. So here would be, it's a loop around the great toe, and it's kind of held in place by the sock and the loop. Here, if they have the Taylor's bunion, which is the same deformity, but on the lateral side of the foot at the 5th metatarsal phalangeal joint. So this is the same exact kind of pad. Here's just a different angle of it, you can see. Comes in a variation where you can have this spacer in there or a bit smaller spacer to keep the deviation, the lateral deviation of the hallux to a minimum. It kind of puts that back and prevents that overriding of the second toe. We've looked at pads like this, or braces like this before, mostly on the lesser toes, where it's kind of buddy splinting it together with a little spacer in between. So that works really well. Now this isn't going to help the bunion area itself, excuse me, the prominence area, but this is going to keep the toes in better alignment. This is going to do both, just like these two. It's going to keep the toes in alignment and do some protection back there. This is like the first one in this row, but doesn't have the buddy connection to the second toe. It just is going to provide some In fact, that's like the one I showed you that for my one patient where she had that sore right here. So this is, she doesn't have a bunion. What she has is an interspace or an interdigital pre-ulcerative lesion, a sore. So while this forabunion would help the hallux move back into a more normal position, not permanently, but while they have it on. Only surgery fixes these things permanently, but this can relieve the pressure and therefore relieve the pain. And that's what we're about in conservative care. And then here's another interspace brace or spacer to keep them apart if there were a sore spot, or if you just wanted to get the hallux back where it belongs when the person is wearing it. It's all about relieving the pain and preventing the rubbing that can cause sores. These are sleeves, aperture cushions, so it has the gel inside of it, soft gel pad, so you can kind of see. And that's nice because it doesn't leave. It stays right where it is all day, and it doesn't take up too much room in the shoe either. Remember, that's an issue. These two, let's go over here first. We've all seen these. They're the self-adhesive felt pads. Make sure that the hole in this is big enough. So it's just felt, so I will often just stretch it and make that hole a little bit bigger because you want it to fit all the way over whatever the prominence is. If it only fits over a part of it, you're actually going to increase the pressure. So these are fabulous pads, but be sure to widen the hole if you have to. You just pull. You don't have to cut, just pull. I love these too. This sticks on there. This is sort of a satin material, and it takes up zero room in the shoe. This works great in women's dress shoes. That's what I have my patients using it for. It's very thin. It's gel that sticks, so it's not adhesive, and it's very, very flat. So it keeps the shoe rubbing or sliding rather than rubbing on the sore. And there's a little bit of gel, so it's not pushing, and you're not adding any additional material there that you don't have to, because in a woman's dress shoe, there's no room for that. So I love these. And you just wash it off, the gel on the inside, and it sticks again. So that is absolutely, you're not going to get this necessarily in a woman's dress shoe, but this you are. It's fabulous. So lots of these kind of devices, again, meant to realign the hallux from its medial lateral deviation, different ways that it does that. Now, does it do that permanently? None of these pads change anything permanently. You can wear it 24 hours a day for a year. It won't change anything permanently, but it relieves pain and makes walking a little easier, makes the aesthetics of it a little bit better. So this one too is used post-operatively, but even if the person isn't a surgical candidate or there's just not something's going to go to surgery right now, these can relieve the pain. I have mostly wearing it at night because this isn't going to fit in a shoe. But for some reason, the feet tend to hurt more at night. I think it's because the nerves, and you had endorphins during the day, lots of other things for your brain to be thinking about. And at night, if everything's quiet, the endorphins kind of go away. And feet tend to hurt more at night. And so that would be the time to give them some relief with something like this. Okay, metatarsalgia, pain on the plantar forefoot. Sometimes we can see right away why. So there's two types of arches. We know about the longitudinal arch, that's the arch we all think about, but there's also a transverse arch, which is across the knuckles, okay? So this picture here is cutting where this arrow on top, it would be cutting across the foot instead of like this. That's what these pictures are showing. So a normal transverse arch shows the big toe and the fifth toe, or the metatarsals, are the ones that hit the ground the most, and these are that arch in between because it has to have some flexibility when they walk. Sometimes, though, it's a reverse. So this is still the top, But now, instead of being up like that, they're kind of an inverse. And what does that do? That puts these three metatarsal heads against the ground, and they weren't meant to be. They are meant to be up in the air. So now all the pressure is going somewhere it wasn't meant to be. And here's another depiction of it with just the third metatarsal, although this isn't much of an arch, but clearly they're trying to show that the third metatarsal is the one out of line, okay? And that might be what it looks like. Now, it's hard to know from this picture. I think that is the third metatarsal, but it's hard to tell. So it might be something like this. Or it could be like this, where that just is the most plantar one. So this is right where the heads of the metatarsal is. I mean, if you look at your hand, it's easier to tell. Your fingers connect into your hand and your toes connect into your foot way above where the actual bone ends. So both in your hands and in your feet, the metatarsal head is way back in the middle of the ball of the foot there. So this is where the metatarsal head is. So second metatarsal head, third metatarsal head, fourth metatarsal head. And different foot, 1, 2, 3, 4. I put those on to give you a mindset to know what you're seeing. It's so far back, some people are fooled into thinking that's nothing to do with the toes, but it is. It's to do with the transverse arch and with the toes. So, well, how could it have to do with the toes if it's in the metatarsals? So pressure from hammer toes in the shoe material. We've all seen that. People use their shoes, their feet as a shoe stretcher, right? What's really happening there? Oh, here's that plantar plate again, where if the plantar plate tears, now that can lift up. So instead of the toe being straight, because the plantar plate mechanism is holding it down, now that toe can come up. So that's one thing that can cause hammer toes. And we talked about the fact there are others. But so now that's tall. What happens? So when that's up in the air like that, and it's hitting the shoe on the top, the shoe is pushing down on that toe. Well, it's pushing down on two places. It's pushing down on the tip of the toe, but it's also pushing down on the longer part of the toe, the proximal phalanx, which is pushing down there. So you get two different sores, one under the metatarsal head and one under the metatarsal head and one under the toe. You don't always get both, but you see my point. So it's called retrograde pressure. The shoe pressure pushes down on it, but it pushes down this way too. So you can get either or both. Retrograde pressure because the hammer toe, the shoe presses on the hammer toe, and it presses down and pushes those bones in. So this is severe, isn't it? I'm guessing that's a bunion. I haven't seen the x-ray. This isn't my patient. And that's who, I don't know the history, if that's an injury or whatever. So she has rheumatoid arthritis and is ambulatory. The large corn or hyperkeratotic lesion on the bottom of her foot is extremely sensitive to touch, so I don't. This is from a nurse that I work with. She pads it with 3 corn pads secured by paper tape. Extremely fragile, discolored, intact skin. There is yellow, odorous material caked up between the toes. You can kind of see it there. She states it's not lotion. She wanted me to take these photos and ask for your advice. Please help me help her. So this was a query I got from a nurse that I work with, as I said. So first of all, it's what's in between her toes is sweat and keratin skin material that's sloughed off, and it just can't get out of there. And so just needs some basic hygiene, although you would have to do that to make sure there's nothing else hiding in there. Are there any sores in there, any infections? So you need to do that. This is, you can't even see this toe. See, it's way up in the air. So I'm guessing that's what's causing this, that this third metatarsal, because this is kind of in the middle, could be the second, but there again, with this being up so high, I'm guessing the shoe is pressing down on that, which is pressing that bone way down. These are not the felt pads. These are over-the-counter foam pads, but the person can reach down there. The hole is big enough. You can kind of see the imprint where this was. So just another version of this. Whoops, let's go back, sorry. All right, so the biomechanical cause. If you know this by now, if the toes are reducible, and that's what's causing that, pull the toes down. That way, you can do it surgically, of course, but short of doing surgery, that's what this is for. The shoe can't push down, but get that retrograde pressure if the boot and splint is keeping those toes down. Now, there's not a metatarsal head that's protuberant. So these were great for that. So if the cause of this is this, use these. Sorry, I had to. This brace depends on the toe being flexible enough to lay flat. It is reducible. So see the cause and effect on that? I love it. We saw these before, plantar forefoot protection, but these are adjusted a little bit differently. The other plantar forefoot protections we saw, protection sleeves that we saw, had the entire area with the gel inside. This, you can see by this outline, only has it where the outline is. So that lifts up the third, fourth, and fifth metatarsals, which leads a little divot for that first metatarsal to kind of fall into. So that would be helpful. We can do that with felt in the shoe, or we can do it in an orthotic. You've seen that. Or the person can wear something like this. So there's many different ways we can take pressure off the plantar surface of that first metatarsal phalangeal joint. And this is one of them. This one is a little bit different, and it goes out and kind of helps straighten those toes out a little bit. And you can see, what this is telling me here is some of these, you can't see the gel at all. There's material on both sides, and others you can see it's only fabric on one side. On the inside, it has the gel. So this is actually, I think, inside out. Back to that pediplast. So this is pushing those toes up. This was a patient of ours that we were a little bit worried about that because he'd been wearing some things under some regular buttress pads under there. But because that toe was straighter and lower on it was just getting too much pressure on that one toe. So we wanted to do something different. That was what was causing this. Same thing. It was that pressure. And his toes were not reversible. They were frozen in that position. So before and after debridement of it, that's after debridement, we made a pediplast piece to go in there that took pressure off of that area and put it on either side. So that's what this was for. And that's what my point was before. You can have special situations where you want to alter the way the pressure is so we don't cause problems with it. And this pediplast is perfect for that. And he can get that on and off, and it'll last him for a very, very long time. Various pads to relieve plantar forefoot pressure. So we saw different types. These are all reusable. The ones on this side are that special gel material that's self-adherent. And you can see the placement for them. So instead of a felt pad under there, here would be maybe your metatarsal head. You can use this. All of these, you just wash them with soap in the sink and dry them, and they stick again if they get skin cells and things on them. So they last a long time. Dancer's pad, but that's that same thing. I think this picture shows it off a little bit. It should be moved over a little bit because here is where that hole should be. That's like the pad we saw in the previous slide where there was no padding under where the first metatarsal was, so that the first metatarsal had a place to go, and it had like a divot there. So you can see some of these. This one might be good on the ball of the foot, and again, the picture, I would move it forward a little bit, not too much because it doesn't go over that hump well, but a little bit further. Although it's hard when the patient's doing it themselves. A lot of times in the seniors, their fat pad in the plantar foot disseminates, it goes away. So they're literally walking on bones, even if their toes are straight. So they're maybe not getting calluses because of this, but they may be getting calluses or just a lot of pain because there's no padding there, and their bones are, all 5 metatarsal heads are hitting on the floor because their fat pad has shrunk away or moved away. So something like this that goes around the entire area of the metatarsal heads would be fabulous for that. These are more the felt, self-adhesive felt versions of some of those. Now here again, remember to, they're just felt, pull those holes so they're big enough to go totally over the sore. You don't want it half and half, so wiggle them until they go over, or use the U-shaped pads like this. Then you don't have that problem. Okay, here's, now this is just as thick as moleskin, so this is more for rubbing, but it can help a little bit if they have lost their fat pad. These are more for things like Morton's neuroma and that sort of thing that you'll know about, to push up the metatarsal heads, and we haven't talked about that. But lots of these, so these are self-adherent. I find, by the way, that the patient can wear these through showers. I've never had a problem. There's a really good adhesive on it, and it blocks the moisture from getting to the skin underneath. So I let them wear them in a shower. I just say, please then stand on a towel, not just your bath rug, those are usually nylon of some kind. Stand on your towel and kind of get the fluid, water out of it, and don't put your socks on right away to let it dry out. But even if it doesn't, because who knows what they're going to do. I've never had it cause maceration, which is the white skin damage that you get from too much moisture. So the felt ones that are self-adhesive, it's okay if they wear them in the shower. They'll last for 2 or 3 days if they do that carefully. So they might need to wear a sock to bed to keep it on, that kind of thing. They can use Band-Aids to hold some of them on, but please have them wear the fabric Band-Aids, not the plastic Band-Aids, because the plastic Band-Aids don't breathe, and I do find some maceration under those. So use the fabric Band-Aids, it's easy to find, and different shapes and sizes. That way the Band-Aid can breathe and the pad can dry out. Love it. All right, various pads. So in your shoe itself, here's some silicone gel step. And you know that we don't have to always have everything full length. And sometimes there's just not room in the shoe for that. And usually, other than a few exceptions, you don't need padding under the toes. You need it just to the sulcus area. And that's what this is. That's the sulcus. So just like a lot of the orthotics that you dispense, it can go just 3/4. So either of ones on either side of this page are fine. The gel, the blue gel in there has is softer, a lower durometer. It's softer, so provide some padding in that way. Here's a couple. This is fabric with, I don't know actually what's inside. I don't think it's gel. It could be. I'm sorry. I haven't used this one in a long time. I know that it's very soft, but I'm not sure if it's nylon in there or if it's gel. This one obviously is gel. So again, for all of these kind of things. Now, having said that, this one wouldn't be good for metatarsalgia, would it? Because it stops back here. So if metatarsalgia was what you were doing, you would need a full-length one, or you would need one of these. But these are good for some of the other types of pain that you can have, heel pain and just proximal to the metatarsal head area. And finally, these are brand new. For a long time, we've had the big Velcro-on knee-high boots that we use for different things, and they've had these pull-out plug systems. But in those boots, there's too much movement in the boot. But now they're being made thin enough and appropriate to go into regular shoes, not dress shoes, but most athletic shoes. You would take out the insert that's there and put this in. And you can adjust them specifically for that person. So maybe under, I'm guessing, the first metatarsal head and the fourth, or it's probably the fourth metatarsal head, maybe there's a pain under the heel. You take out these little plugs that are there and you create your own divots, and it just works really well. And they come in different layers, so a stabilizer that's a base layer, because you don't want that necessarily right against your shoe. It needs to be more stabilized than that. So that would go in the shoe. You've taken the other insert out that the shoe came with. Put the base unit in, and then you've adjusted this to the areas that need the pressure relief. Then put it in, and there's often a top layer as well, and it's usually this plastizote material, also called Poron. Oh, sorry, Poron is the blue, is the light blue. So there's different materials they're making out of it. So the top and the bottom, and then this is in, excuse me, the peg part is in between. And okay, removable plantar plugs unload targeted areas, offload sore spots to relieve pain and reduce friction, minimize skin breakdown due to repetitive microtrauma, distribute pressure away from sensitive areas, and prevent, relieve, and heal. It's amazing that now you can get these and customize them to go in a shoe that will hold them in place, as opposed to the big knee-high walkers that we used to give them. They A, didn't wear them as often because they were knee-high walkers. Nobody likes those. And B, their foot would move too much in it. So this can go in an extra depth shoe if they have those, and that's a common thing. Or if it's a well-fitting and spacious athletic shoe. You can get versions that'll go into that. That's a more permanent thing. They would have this in their shoe, and some people can't afford to or don't have access to pet orthics or orthotists where they can make some of these kind of things. Your office may not make these sort of accommodative orthotics. They may make more dress or sport orthotics. So there's a real place for this, and certainly in my wound care practice, we would use this quite a bit. All right. Well, we've gone through quite a bit. We tried to cover several different common deformities, talk about what's causing them, what you can do about them, some of the pitfalls of it, some of the hints, like always draw an arrow to help your patient know which direction is forward or which part is top, something like that, or a left and a right, L and R. It's so fun working with the patients and getting them something like these devices and pads that can relieve pressure and pain and let them lead happier lives and more active lives. So I hope this has been helpful in introducing you to some of them. Please try them out, and I think you're going to see the patients are very appreciative. So thanks a lot. Take care and go out there and get those feet better. Thank you. Bye-bye. Turn this on. And once was enough. Hopefully that gave you an overview of it. And I have here for you to see one of those pressure off devices that was in the last bit here. The little thin piece that goes against the shoe. On this one, let's see if you can see, it's shiny. It's a really soft material here. But this is the bottom of it, and you can see it's all set up to take off different ones. So you might mark, yeah, Bonnie has the catalog. You might mark, I don't know if you've seen one of my other videos where I put lipstick on the foot where the problem is, and I have them stand on the device and see. Then you know exactly where on the bottom to take this off. And these just come out, and as with any of these sort of holes, you're going to take out a little bit wider, let me get this, sorry, a little bit wider than you think, because you don't want to pinch the sore spot. You want to have it more of a, I can't talk and do this at the same time. So like you want to have it be able to go like that instead of a drop off. So that might be underneath the third metatarsal head. So that's going to be down, and the third metatarsal head's going to press there. And I can actually feel the dip right there. And it's quite a bit smaller. This is half the thickness of the ones we were using in wound care for so long. So, and they also have them at the bottom. So it's really great. And these will last for months. It won't last forever, but it'll last for months. This is durable material. And if you take the wrong one out, you can put it back and it'll go back. So I wanted to show you that. A couple of questions, and we'll go over some questions. One of the questions was, where did we get that? They have a wonderful catalog. Can I do it? They have this and smaller little catalogs. Oh, Bonnie's got it. Good, thanks, Bon. And smaller catalogs. And if you, Bonnie, tell them about if they call, and I guess I am promoting it. The CE is over, so now I'm promoting it because they have good products. But Bonnie, tell the folks how to get their own.
Right. Well, this is important information to know. I actually, there's a paper shortage now, so you can't get a case of them, but I get them 25 to 50 at a time, and I use them as a teaching tool with my clients, and I give them out to the clients. But the number on the back, I put it on the chat area off to the side here, the contact information. Their phone number is 1-800-PEDIFIX, and their website is www.pedifix.com. And there is an option there as a healthcare professional, a foot care professional, you can sign up to get wholesale rate. And there are some things that I get on a regular basis from Pedifix because it's a really good product, and it's like 40 to 50% off on the items that I get. So it really behooves you to get on the list, and then they will send you flyers. And we've gotten free samples, haven't we, Debbie? Some really good things.
Oh yeah.
Yeah, really good things. So the information is here off on the corner in the chat column. Go ahead and write that down. And this has the price list in it for the clients, and then you have a separate price list for foot care professional. So highly recommend it.
And the patients, the clients love it if you have it for them. They don't want to have to go find it. And these days, things being what they are, supply chain and all that, most of the pharmacies I find have the cheaper versions of this, and they don't last as long. So if you can have some of these of your favorite ones for them, and it's okay to mark them up. You don't have to. You can make that decision. You can give it to them, but it's also okay. You're buying it wholesale and marking it up to the retail. That's okay. That's nothing wrong with that. And you offer them the choice. You know, we have some here if you'd like it, but you can also get them at any pharmacy. And they almost always will say, I'll just get it here, because they don't want to have to go to 4 pharmacies and find it.
Yeah.
So you're actually doing them a favor. Bonnie and Debbie, have you found that? I think you guys work with these things, don't you?
Yeah, I stock extras too, and Tinactin for that matter.
Yeah, there are some things that you just can't stock because it comes in small, medium, and large, right side, left side. So it's cost prohibitive to, keep them in your cart. But they love to take these little catalogs home, and they can order them online themselves or call.
Order them on Amazon from Pedifix.
Yeah.
Right.
And I have to say, Bonnie's more to the letter than I am. Everything is large in my world, large or medium. I don't go. Some have to be right or left, particularly those buttress pads here, but most of them, it's either foot, but I just go with the large. And if a particular person needs it medium, nobody needs it small. I'm sorry, that's just not my world. I might order a couple that are medium on some of these, but I just get large.
Good to know.
Don't get crazy with that.
Mm-hmm.
So let's see. So great. Couple of questions.
Angela Fry wanted to know, how long can the U-shaped pads stay on?
I'm guessing you mean the felt, the adhesive back felt. They can stay on. It depends on the person's activity level. I've seen them stay on anywhere from 1 day to about a week. It depends on a lot of different factors, including whether they're holding it on with the Band-Aid, if they take showers, if they are very, very ambulatory. they're fine. After, now when I use them, because I'll use that same thing, let's pretend this is a normal insole, not the fancy one. I will use some of those and put it on the bottom of an insole, even their own sometimes, to push up or to create this same kind of thing, but using one of those U-shaped felt pads or some other version. So I sometimes will put that on the bottom of their insert, and I will put a piece of tape over that, like athletic tape, so it doesn't move around, and that'll stay there for a long time, but it's just felt. So it flattens out. So each time when they come back every 2 months, I take it out and replace it. And sometimes I have to put 2 on there to make it high enough. So I use those self-adhesive felt pieces a lot. You can get that kind of self-adhesive felt in a roll. I find for the most part, I'm cutting out that same sort of shape anyway, so I just go with the pre-cut ones and kind of cut them a little bit more to go where I need them to go. So if you're putting it on the bottom of the shoe where they're not walking on it and moving it, then it'll last a couple of months. If you're putting it on their foot, it's from a day to maybe a week. Okay.
Pam would like to find out how people would find out about the difference in leg length.
That's a whole other class. So it is, that's a big class.
Yeah.
You can tell with your patients how they walk and if they have a bunion on one foot versus another or calluses. You know, with our seniors, I don't do anything about it for the most part. Sometimes I will, because walking is an automatic activity. And they've been walking with that deformity for 80 years. I can't go in there and fix it because I'm going to knock everything out of alignment. They already have the arthritis they're going to have from inappropriate motion. And if I do this to them in a different way, now I'm going to create new wear points on their joints. So, and their automatic walking is thrown off too, and they're more likely to fall. So I don't correct it in anybody like over my age. Just be careful with that. So I think that's probably not something we'll even go into because it is a whole class by itself. And for most of our clientele, our patients, it's not appropriate to do anything about it. The damage is done, and you're just going to throw off some automatic reflexes. But good question.
Barbara Ann wants to know about the use of moleskin.
Moleskin is great. It is more for shear forces, for friction protection. You could use it. You saw that one pad I liked that went on the first, that's more like a first metatarsal, the first metatarsal head to prevent, but that was to prevent shear forces, the shoe rubbing. Especially some of the seniors wear their shoes loose and they tend to rub. So if the rubbing is causing a problem, that's where the moleskin comes from. I don't use moleskin on my seniors because the adhesive tends to be too strong and it stays on too long and they eventually pull it off. And if I'm pulling it off, the skin can get hurt. I don't like moleskin on my seniors.
Okay.
But it's a fine product. And that's just mine. I'm not saying you're wrong if you do it. Just watch what part of skin you're putting it on.
It's a good question.
Yeah.
I see other questions? I haven't been.
That would be it, wouldn't it?
I thought I saw some more.
Covered so many things.
Yeah.
Yoga toes. Oh, yeah, we're not going to go over yoga toes. That's a whole other thing too. Some of these are just much longer conversations than we have. What was I going to say? Okay, I went over that. Bonnie went over how to get that. Chris, are you here? Chris from PettyFix is often watching.
He's not here.
You see him?
No.
Okay. I didn't know if you had any questions for him, but he's been a real good supporter ever since we started and had a booth at our first conference, which, by the way, I'm working with a company now. We're trying to put a conference together for the spring. So I know a lot of you are asking about that. I don't think we'll do it in the fall. I think we'll do it in the spring and do a really nice one, a big one. And I don't know where yet. I think Minnesota, but it might be Denver. I don't know. We're still working that out. Let's see. Okay, Arinda, are you? Oh, Arinda left. Arinda, are you here? So Arinda is our representative from South Africa, from our chapter in South Africa. And she had a, oh, yes, thank you for that. She had a thought for you. Are you here, Arinda?
Yes, her mic is
Yes,
on.
yeah.
Oh, hi.
Yes. Hi.
So I was going to talk about your Facebook situation. I know that you said it might be till next week, but do you want to explain that for them? We want to support her. She's doing such good work.
Yes, we are very excited. We are getting ready for our next training session that starts on the 19th of July. So the students are very excited. So we're starting with the interviews next week. And we decided to put a little ad on Facebook to just give a few more students the chance to apply for the bursaries. Yes, so we set up a little Facebook advert that starts with Dr. Julia's face, so it's quite sweet.
Well, no, you want to do a good thing, not mine. That's fantastic. So when it goes up though, it would help her, as a lot of you know, which I barely do, if we did likes on her entry there. So how do they find that? And it'll be next week, you said probably. But how do they find?
They need to, Benalie is going to explain to you, my daughter.
Hello, everybody.
Hi.
So, yes, you put it on Facebook. My brother is the IT guy behind everything, behind the scenes. So then he's going to put it on, and we'd really appreciate it. We'd appreciate every single like. Every like counts. So we'll let you know. It's going to be quite easy. We just have a few problems on this side because we have different Facebook accounts. So now we just have to figure out which one do we have to post it on. But yes, we'll keep you updated, and thank you so much for your support. The Facebook page's name is the Foot Care Family. So, but Dr. Julia will send it to you, then hopefully you can just forward it to the rest of the people, and then we'll make it easy for you. Thank you so much.
So we absolutely will. And if you've been on, I reworked the AFCNA website. It's a little more modern now, but we also feature Arinda and her wonderful project there in South Africa. So, and those of you that were on our webinar last month, we kind of showed some of that. So we're so honored to be part of what she's doing there. She's just making such a huge difference. And anything we can do to help, we're so excited to do. So we will go on and do likes. Is that a good thing? Likes?
Thank you very much. Thank you so much.
You're so welcome. And so, yes, and also I'll post that. I'll post her information on the website too.
Okay,
so,
thank you so much.
We will get that put out so we can get a lot of likes on that.
Thank you.
Thank you. No, you are doing such amazing work.
Pam would like to raise awareness about the blog. It's a great place for sharing expertise and for networking with each other.
And now we're using the blog that's actually on the AFCNA website. It says blog/forum because I guess it's technically a forum. I barely know these things. I need to hire Arinda's son. So go on the afcna.org. Remember, it's .org, otherwise it's the Alpaca Farmers Consortium of North America. That's what afcna.com is. So you have to do afcna.org. And of course, you have joined. It is free. And I'm shocked. A lot of you who are certified are not members. I know. I am shocked as well. I go on to look for a couple of you, because I just mailed out a lot of the packets for certification, and I couldn't find some of your addresses because you weren't members. So please join. But that's the forum, so go on there, and I hope it'll be a little bit easier to find now that I've redone part of it. But please look at.
Kim West made a comment about the new blog format as well, and she really likes it. So,
Oh, good.
and she's been responding on there. Thank you, Kim, for all of the input that you put on there. Great.
That's fantastic. And if you, what you do is you check a box and you subscribe to it, because then you get notified when someone posts something. Okay, thank you. Yeah, we want to try to get that. And you can post pictures on it. It kind of walks you through it, and I haven't tried it yet, but I understand it's doable. We had another question, excuse me, before we started from Christine. Or no, was that the one before? No, about amputation as a possible treatment. Was that the, I'm sorry, hold on just a second.
Yes.
So, yes, there are a couple of ways. What she's asking, I think, is when you have rigid contractures, as opposed to this, the rigid contractures, it can be just at the just at the distal joint or the distal and the proximal joint. There are a couple of different very simple surgeries that can be done. One of them, actually, the woman in the pictures a few minutes ago with that toe brace, the one that I cut up to fit better, she's in her 90s, God love her, and she has that ongoing problem. And right now she can reach down and put that pad on herself. The toe brace, is that what it's called? The new one. But you know, how long will she be able to? So I'm not doing surgeries anymore. I asked a podiatric surgeon friend of mine to do it, and he's going to do a very simple procedure where he just takes a little piece of the bone out, which is a very common procedure. It's called an arthroplasty. So no pins and no trying to get it. You know, she's obviously not running races. So if you take a piece of the bone out, then the toe is still stable because fibrous tissue, scar tissue forms inside there. So it's a stable toe, but now it's a little bit shorter toe and it can go flat. So we're doing that one on her, and that way she won't need these anymore. And that will solve her problem. Also, sometimes amputation of a toe, which I know sounds severe. And I think I read someone was asking about, would you just take that bent part off? I know podiatrists that do just take like the distal section of a toe off. Usually, in my experience, when I was doing surgeries, by that point, you have a lot of gnarly alignment. So I would tend to take the entire toe off, which again, I know that sounds severe, but I'll show you some pictures, I'll get them up, where it's not at all severe, because the other toes, there's not room for it anyway. Remember that picture we saw a few minutes ago where the one toe was, the second toe, third toe, was totally overriding the rest of them? You're not going to miss that toe if it's gone. Visually, you're not going to miss it. Those other toes have filled in the gap already anyway. And it 100% for the rest of their life solves the problem. So there are simple surgeries that are very quick to heal from. They're not off their feet. It's not a fall risk, except maybe the first couple of days when they have to be kind of walk flat-footed, be a little careful. But choosing the particular type of procedure carefully is very appropriate for this. What is not appropriate is the same surgery I would do to a 50-year-old, because that is not appropriate on a 90-year-old, because that takes a lot longer to heal. We're doing more extreme bone modification and movement, and we have K-wires in to hold it straight for 6 weeks, and they're in. No, you do not do that with someone who just needs to be more active in their everyday walking around normal activities. So do I send them to other surgeons now that I'm not doing that? Very carefully. I pick those people very carefully, because I don't always trust that someone looks at the whole picture of who this person is. So yes, surgery is very appropriate, even if their blood flow isn't the best, because if they're getting, like the one lady that we're talking about who I cut that pad up for, the gel pad, she was getting bad infections about 3 or 4 times a year. Now, she healed well from them, but eventually it was going to be something that didn't heal well. So is it safer for her for the rest of her life, 3 or 4 times a year, to get a sore and an infection there, or is it safer to do a little surgery? most of the surgeries I described have like a 1 or 2 inch scar or incision at most, and it's superficial. So they heal within a couple of weeks. So yes, it's appropriate, but it has to be considered a very conservative method. Let's see, there was another, was that the question from before where I said if I don't answer that, ask me? Who was on? I should have written it down.
She also asked about gait and balance. Does that procedure affect gait or balance?
No. Oh, that's a great question. No, 0, because they're not walking on that anyway. If the toes are up like that, those toes are not weight bearing, period. I could take all of those toes off and it doesn't affect gait and balance at all. They are not weight bearing and they're kind of in the way. So no, I mean, you'd have to obviously evaluate it on an individual basis with each patient. But overall, no, if it's up enough that it's in the way of other things, it's not weight bearing. And it's certainly not able to use the flexor tendons and the muscles to push it down so that you could propel off of it. That's what we mean by weight bearing. It's not helping you at all. So that's a fabulous question. The fact that you asked that means you really understand functional gait. So good job. It's fine. Okay. Let's see.
One person had asked about professional liability insurance providers, and I put out the name NSO, Nurses Service Organization. If any other nurses want to put the name of your provider in the question box there so others can see that there are other options and have some choices.
Yeah, absolutely. Lisa Kowalski says she's seen some of these things on My Feet Are Killing Me on TV. I can't even watch that.
For sure.
So you mean the Pettifix pads and things? Do they use them? Most of us do. I know I saw one comment on here that their podiatrist had never seen a buttress pad. I'm like, okay, where did they train?
Yeah.
But I'm just saying.
Yeah.
Let's practice some conservative care. Let's see. So anybody else?
Good timing.
Yes. Oh, look at that. Well, I have to say, this is the most people we've had other than our Christmas program. So I'm very excited. I hope that you will come back and we do this the second Thursday of every month. Try to do a different topic. We have them set up for a while. What do we have? July, I'm going to do the homeless and underserved clinics and more about the guidelines. In August, we're going to do fall risk assessment. And in September, we're going to do another case study.
Ooh.
So if you missed this, which you wouldn't be listening if you did, as Debbie said earlier, by Monday, God willing, and the creek don't rise, it will be up in the cloud site. And that address is on the bottom of your invitation, and it's there in the chat box, tinyurl.com/foot care meetings, plural. So, and you'll have the CE certificate is there, the handout is there, and the video itself is there. Now, I don't take just the CE part of the video. So if you don't want to watch like the whole 2 hours, you can obviously fast forward through all our comments and chit chat at the beginning and just watch the CE if you want to do that. But you'll be missing the fun part if you don't let us talk to you. All right. Anything else? Oh, Nadej, you're welcome. Nadej is thanking me for the policy and protocol. Yeah, it takes quite a bit to do that. But see, Nadej, who's a nurse practitioner, knows that she needs that, and she's in the process of making it, and that's why I'm putting that up there. And Nadej, if you find something different that you are including that we can include in ours, please let me have it. Let's put it out there because we've got to support each other with this. And part of our battle is foot care nursing being recognized as part of the healthcare community. So the more we can do to conform to healthcare norms, like having guidelines and directives, accepted. And that's why we work so hard to do this as your association, which you should join.
Great.
All right. So thank you so much for coming. We will see you again next month. And again, if you have issues, business type issues for starting a clinic, guidelines, resources for funding and that kind of thing, let me know. We might even do a smaller little version of this with just those of us who have those kind of resources, so we can plan and make a good presentation for the big program next month. So you can reach me at juliaoverstreet@yahoo.com. It doesn't get answered immediately, but we're trying to put that together. So Bonnie, Debbie, any other last comments?
No, thank you for being here.
It was a great presentation, Julia.
Thank you so much. Now, oh, one other thing I have, and it's up, I think it's still on in the cloud. There's another whole hour on how to make some of those pads yourself. I may show that later this year. I did that. We did that last year sometime. So it's still up there, I think. And those of you that have the CEs as part of the package, it's in there. It's called How to Make Your Own Pads. So, all right. Thank you all very much. Have a great evening and stay safe and go clip some toenails. Thank you so much.
Bye, everybody.
Bye.
Oh, no. Take care. Bye-bye.